This is the Psychedelic Medicine Podcast.
Hello and welcome to the next episode of the Psychedelic Medicine Podcast. I'm Dr. Lynn-Marie Morsky, your guide on this journey, and today we're going to be discussing psilocybin for anorexia nervosa with Dr. Stephanie Knatz Peck. Dr. Knatz Peck is a clinical psychologist and associate clinical professor at the University of California, San Diego, with an expertise in eating disorders. She conducts clinical research on novel treatments for eating disorders and has been involved with clinical research evaluating psychedelics across a variety of mental health indications in the capacity of a researcher and therapist. She published the first ever report on a clinical study evaluating psilocybin for anorexia nervosa. Now, before we get to Stephanie, just a reminder that the Psychedelic Medicine Podcast is for educational and informational purposes only. Nothing here is to be construed as medical or legal advice. And your reminder, as always, that if you are a clinician and you would like to learn more about psychedelics and how they could be effective options for your patients, please check out the Psychedelic Medicine Association. It is our mission to get you educated and feeling comfortable discussing psychedelics with your patients so that if there is a psychedelic therapeutic that is legal, available, and appropriate for a patient, you feel comfortable referring or prescribing when appropriate. You can find us at psychedelicmedicineassociation.org. Now, without further ado, thanks so much for joining us today, Stephanie.
Thank you for having me, Lynn-Marie. Happy to be here today.
I appreciate you being here, and I'm really looking forward to this conversation. If we could start just giving us a little bit about background about your work prior to psychedelics in working with patients who have eating disorders and some of maybe what therapies you had used and how effective or maybe not effective those had been.
Yes, absolutely. Yeah. Well, I've actually spent my entire career specializing in eating disorders. So, from my early clinical postdoc, pre-doc training. And so I've worked really extensively on a clinical level with, hundreds and hundreds of people with eating disorders. I direct an eating disorder program at the UCSD Eating Disorder Center that is an intensive kind of family therapy program for both adolescents and young adults. And in addition to doing clinical work with people with eating disorders, I've been involved. We have a neuroimaging lab. And one of the missions at our center is really to kind of help develop novel treatments that are just more efficacious for people with eating disorders and specifically anorexia. And the reason for that is because there are such limitations in the types of treatments we have available. So I am trained in all the sort of quote, evidence-based treatment models for eating disorders for adolescents and adults, including family-based treatment, cognitive behavioral therapy for eating disorders, and a bunch of other treatments. And so I have conducted those on an outpatient basis and also in our partial hospitalization program. And actually, much of my work, a lot of our lab's work is really focused on understanding biological vulnerability factors that predispose someone to the development of anorexia, which include personality traits and core temperament traits. And a lot of my work in the clinical research realm has really been about how do we take that information and turn it into other novel treatment models. So much of the kinds of types of treatment approaches that we use really focus on helping people kind of identify their own core personality traits that might have led them to develop an eating disorder, things like perfectionism and achievement orientation, which we know are, again, predisposing factors overrepresented in people who develop anorexia. And instead of trying to change those like we often do in treatment, it's really about having people identify those as strengths and learn how to basically channel themselves into those personality traits outside of eating and into other realms of their life to be successful. So that's another model that I've spent a lot of time working on. But I will say that, having treated, I'm a clinician first, clinical researcher second, I would say. So my passion, my heart lies with treating patients. And I've spent a lot of times with patients. And the thing that is so striking when you treat people with eating disorders is having people show up over and over again, really, really wanting to recover, maybe with some ambivalence, but truly wanting to recover and hitting up against the walls of how well our treatments work. So, which is, again, what has driven me to this mission of trying to help develop novel and better treatments for people.
Yeah. What was a typical course of therapy? Would you say, obviously psychedelics are not widely available, and we're going to talk about that. But,
Mhm.
prior to the possibility of those being treatment options, what kinds of things do your patients generally get currently?
Yeah, it's a really, really good question. So, generally, I mean, I can speak for the US, it's somewhat variable across the world, but essentially, there's kind of two main pathways. There's an outpatient pathway where, again, traditionally people would be seen once a week in outpatient therapy by a therapist, clinical psychologist, hopefully someone who specializes in eating disorders, but sometimes not. It's really difficult, I think, for consumers to navigate that space and figure out what they should be looking for and kind of seeking out a clinician, right? And there's all sorts of therapies available out there for eating disorders and all sorts of people doing different things. And then the alternative pathway is kind of like the higher level of care pathway, which looks like day treatment centers, partial hospitalization programs, residential treatment centers, and sometimes inpatient if someone's medically unstable. Those programs that people can access are, there's not a lot of evidence available kind of helping us summarize how well they work. And I would say across the board, everyone in this field, I think, has their heart in the right place in trying to help people with eating disorders. But a lot of our treatments are really limited. So when you look at their efficacy, they're especially for adults, it's pretty low. A lot of people do not respond to first line treatments. A lot of people end up in residential treatment centers or PHP programs and end up relapsing, right? Relapse rates are really, really high. And these are really costly treatments and obviously time consuming treatments as well. And so we have a problem in our field and a desperate need to establish, I think, better treatments or, I think more integrated treatment models that involve multiple modalities.
You have a paper in Nature, and the first line of the abstract of that paper says, "Anorexia nervosa is a deadly illness with no proven treatments to reverse core symptoms and no medications approved by the U.S. Food and Drug Administration." I don't think I'd actually thought through that before, but that's true. Even my years of prescribing, I think I would have kind of assumed maybe they were given an antidepressant in some off-label manner, trying to, address some, like you said, underlying thing that might be leading to this. But you're right, there's no approved medication. And so this has to be kind of therapeutic in ways that, like you said, if therapy outpatient isn't working, then you have to step it up to an inpatient or hospitalization. And even more importantly, in that same sentence says right off the bat, this is a deadly illness. This
Yeah.
is, I think people maybe underestimate that, oh, this might be kind of it's a problem and oh, that person looks thin or something. No, this can be actually deadly because those electrolyte imbalances and the malnutrition, these are, serious and threatening parts of anorexia. So thank you for the work that you're doing in this condition. And can you tell us the prevalence? Because I think the last time we had Dr. Reed Robeson on years
Mhm.
ago talking about eating disorders in general, but I remember him telling us the prevalence, and I thought it was higher than I had thought. So can you shed some light on that?
Yeah, that's a really interesting question. Yeah, and I mean, so the prevalence rates are about 1%, and for anorexia specifically. For other eating disorders, they're slightly higher, and they've actually been consistent over time. But I do want to mention that that is for anorexia, and we have all other sorts of categories of people who struggle with restrictive type eating disorders. That would fall into that don't meet full criteria for anorexia and would fall into kind of like the catch-all diagnosis of OSFED or other specified eating disorder not otherwise specified. And I say that because that's a huge category of people, some of which have restrict a lot of behaviors that look like anorexia, but again, don't meet full criteria. And that is a population of people that is undertreated and actually in some ways is the most dangerous type of illness you have. In our paper, we included, and I'm happy to report this was actually kind of a critique of our paper, is that not everyone met full criteria for anorexia nervosa, but we actually included people who, quote, were in partial remission. What that looked like was people who who had a previous history of full anorexia, but didn't meet full criteria and still struggled with significant and severe eating disorder problems that look like sub-anorexia. And again, that's a population that has been understudied, undertreated, and has a lot of risk factors included as well. So
Gotcha. And would something like orthorexia fit into that?
Mhm.
Not otherwise specified. If you could tell people a little bit, I think not enough people know this term, and I think there are probably a lot of people that qualify for this term and don't know that it exists. Can you tell us a little bit about that?
Yeah, and did you orthorexia, you mean?
Yes.
Yeah, no, and orthorexia isn't actually in our psychiatric diagnostic kind of like lexicon. That's not a diagnosis. However, it's just I would say it's a version of anorexia that you're right, has become maybe more popular, and probably uh, is under-identified. And that just looks like people who end up spending a significant amount of time preoccupied and, using behaviors that are focused on weight and eating. But instead of fully restricting, there's kind of an over preoccupation and sometimes even obsession with other things like clean eating or cutting out certain foods or following certain ritualistic diets, ritualistic behaviors around exercise in a way that actually is life interfering, right? And meaning that like they're over prioritizing sometimes those behaviors over other life values and other life activities, actually.
Yeah, thank you for clarifying what that is, because I think with the prevalence of so many evidence-based nutrition and longevity and biohacking and all those things, and I am just going to go ahead and say I'm speaking from experience here. You get so much data that you're like, oh, this thing is seed oils are bad, or this thing is bad, and then you get down to where like three
Yep.
foods are allowable, but are those in the paleo diet you're following or the keto diet you're following? And do I have a
Yes.
six pack today versus not yesterday? And it's more of like a fitness uh, food preoccupation and for your health. And so you think it's a healthy preoccupation because it's for your health, but it's still, like you said, it can actually overrun your life. And so I
Yes.
think maybe if people are listening and they start to identify with that, know that that is, like you said, not in the DSM at this point where it's a diagnosis, but I think it is a phenomenon worth, maybe identifying and pointing out.
Exactly. Yeah, I really appreciate you, Lynn Marie, kind of describing that so vividly because I think a lot of times and this is some of the research we've done in our lab, but is like what distinguishes someone who like why lots of people diet, lots of people follow these very, very prevalent, invasive, now common, popular diets, right, for health. And why does not everyone develop anorexia, right? And that's to my point around that. We think that there's specific personality features that predispose someone to kind of engage in these dietary restrictive processes or behaviors or actions or kind of modify their lifestyle around exercise and food, and then they fall into anorexia. And the thing that distinguishes those people is that sometimes they have these sort of predisposing factors like a lot of anxiety or preoccupation, an ability to be like highly self-disciplined, right? There's a lot of processes at place that would cause a diet to go awry and turn into anorexia. But that's not every person, right? And I often will say that people with anorexia are like the 1% of people who have to be careful about not taking in all this information on the news around longevity and intermittent fasting and all these things that could actually set someone up for restricting that are fine for everyone else. But if you fall into this category of being a certain kind of profile of person, that could actually be really risky for you to go down that pathway.
Yes, thank you for pointing that out. I really appreciate that. And before we get into your first study, I just wanted to ask one last question. Has there been a genetic hereditary component found
Yeah.
with anorexia?
Yes,
Okay.
definitely. There's some really good data suggesting that there is a genetic predisposition. And it doesn't mean that there's like an anorexia gene, though we do see kind of, since there is a genetic, predisposition, there are often people who are treated who have a history of someone else in their family with eating disorders. But a lot of that genetic predisposition shows up in kind of core temperament and personality traits. So we see people who have a tendency to have a lot of anxiety or kind of some of the other things that we see overrepresented in this population, like perfectionism, obsessionality, things like that. And we believe that the genetic predisposition comes from those traits.
Makes sense. And as we get into your study, the one that is published in Nature called Psilocybin Therapy for Females with Anorexia Nervosa, a phase 1 open label feasibility study, I wanted to ask, what's the prevalence in females versus males?
Yeah, so that's a really interesting question. And the reason why we labeled it females is because this was a very small pilot study, the first of its kind, really, really meant to establish safety and kind of understand whether we're getting an early signal to kind of that we should pursue further for evaluating psilocybin for anorexia. And so we studied all females, and that was not an that wasn't a criteria. It just happened that we got all females. And even when we look at our larger database of kind of interest, it was predominantly female. And that sort of lines up with what we know is true for prevalence rates in anorexia. They're overrepresented in females. And there's a lot of open questions around that. My colleague Stuart Murray at USC, who studies male eating disorders, would say that some of that is related to assessment and diagnosis, right? That anorexia might look different and it might be under diagnosed in males, but there might also be some kind of hormonal elements and kind of neuropharmacological elements that predispose a female to developing anorexia over a male as well.
Interesting. And I also wonder, do societal elements also lead more to sending females in that direction?
Yes, exactly, too. And there is definitely if we look at what the etiology of anorexia, it isn't just biology, obviously. I mean, I can't tell you, I've read and conducted, again, hundreds of intakes. And usually when we ask people, how did this start for you? They will say, oh, well, I was trying to be more healthy, or I decided to cut this food out, or decided to eat more sugar. And then began the story, right? And a lot of people do that and don't develop anorexia. But to mention that, why do people even take on those behaviors in the first place, right? A lot of that has to do with societal messages. So absolutely.
Yeah. Okay. If we could get into this study, can you talk a little bit? You said it was a small pilot program, but what did it look like? Can you talk about the setup? Did they get therapy before and after? What kind of substance they got, and how was that dosed, and that kind of thing?
Yeah, thank you for asking. Super happy to talk about that. So I'll talk about the study design first, just to kind of get the basics down. For this particular study, again, we studied 10 females who met either full or partial criteria for anorexia. And in this study, they received one high dose of synthetic psilocybin. So that was a 25 milligram synthetic dose, which equates to what is kind of commonly referred to as a high dose, alongside sort of like a psychological support model that looked like meeting with a PhD therapist for 2 sessions prior for preparation, and then 2 sessions after for integration therapy. So we followed the sort of traditional setup for psychedelic-assisted therapy, quote unquote, here, but it was definitely a brief model of treatment.
And was there a therapist or co-therapist team there with them during the medication session?
Absolutely. Yeah. So there was kind of aligned with traditional models of, psilocybin treatments. I would say that in addition to the prep and integration sessions, there was psychological support offered and, present for every participant during, with a team of 2 clinical psychologists. Yeah.
Very nice. And I love that you brought up that we always bring these studies up, and they're always using something like 25 milligrams of synthetic psilocybin. And I want everybody to remember, this is not 25 milligrams of the kind of psilocybin you get out of the ground. This is
Exactly.
that would be a very, very large dose. This
That would
synthetic
be,
is
yeah.
different.
And we don't even know what that equates to, if we're kind of equating that depending on a whole bunch of different factors. But I will say, while we're on that topic, that in our paper, we report on psychedelic intensity scores using the 5-dimension altered states of consciousness. And we were reliably able to occasion a strong psychedelic experience. So that kind of indicates that, that the dose was able to actually occasion a psychedelic experience of some intensity there.
Nice. And can you talk a little bit about what you found in your study?
Yeah. So I love talking about this because, we published our paper in Nature, and it was a safety study first, and that's really important. And it was also, we have a word limit there. So I have so many more things to say about these findings. And I think depending on how you read the article, it can be interpreted in a lot of different ways. But here's my story around what we did here and what my opinions about our findings. So first and foremost, it was a safety study. So we were able to, and that's important because, we're dealing with something that distinguishes anorexia from other psychiatric illnesses, is that it is illness that really results in a lot of physiological vulnerability across all body systems, right? And so while it might be fine to just assume that some other psychiatric illness, like we can reliably assume safety, with this particular population, I think there's cardiac issues, there's serotonergic things that affect cardiac issues that really we needed some safety data on. So first and foremost, we were happy to report that we did not there was no reported serious adverse events. And overall, the treatment was safe and well tolerated. So that's really exciting to report. And we hope that that can pave the way for, like future studies. One thing I'll note, because it is a safety study, that we did find is that 2 out of 10, so 20% of our population did develop hypoglycemia after post-dosing. That's concerning. That's something that we really want to note for future studies and for other researchers, because hypoglycemia, low blood sugars can be a signature of anorexia, obviously, due to restriction and low blood stores, and are also extremely dangerous. And so we don't think that was a function of psilocybin per se. We actually think that that was related to a period of prolonged fasting that often occurs, as you know, in long days of psilocybin sessions where there's a reduction in appetite. But it's something that we really want people to look out for and monitor, right? Because that can be a really dangerous outcome. We were able to treat that, and it was resolved or I guess I should say we were able to observe and watch, and that resolved itself in 24 hours. But from a safety perspective, our data was really strong. And then of course, we were looking at preliminary efficacy. Again, I just want to note this was a very small study, so the results are preliminary, and like bigger studies are definitely needed. But broadly speaking, our main measure was looking at like, how does this potentially affect eating disorder symptomatology, right? Like, how does this potentially work on eating disorder symptomatology? That was our main question. So we used the eating disorder examination, which is like our gold standard measure for assessing features of eating disorders. Looks at weight concerns, restriction and restraint, shape concerns, eating concerns broadly. And what we found is out of the 10, 4 people had basically went from having elevated scores. So they, if you use that as a diagnostic measure, the eating disorder examination, they fell into the categories of meeting criteria for anorexia. And post-treatment, at 3-month follow-up, they were within community norms, meaning that their scores dropped into what we would consider to be a typical level for a person without an eating disorder. To me, that is incredible and significant because, for one, this is a brief treatment. We had 1 dosing, right? And this is a brief period of time, 3 months. So that's really significant. And especially when you compare that to our currently available treatments for adults with anorexia, right? Like, we know that if you look at treatment studies, in large rigorous studies where they've compared treatment models to control conditions, they've performed equally, meaning that there's no treatment that demonstrates primacy. So for us to have been able to do a brief, intensive, albeit, treatment and show that 40% of people responded on eating disorder psychopathology, that for me is really meaningful. And so, like, I think it's important to take that into context. That also means that there was a variety of people who actually we weren't able to affect change, right, on a clinically meaningful level, right? And so there's lots of questions there about why is that, and what differentiates the 4 from the other 6, and all of that.
And do you have any thoughts on what those factors might be?
Yeah. I should say that, I was investigator on this study. I'm a clinical psychologist, like I said, with my heart in clinical work first. So I was also the primary therapist on this study. And so then I had the great privilege of walking people through the treatment, but also spending a lot of time collecting qualitative information from them. So from a statistical standpoint, we tried to run correlations between all sorts of different things, like what is different about these 4 people, right? Potentially in demographics and how they showed up and their severity and their weight. And we did not find any correlations between any of those characteristics and outcome. On a qualitative level, just working with these people, I couldn't say, oh, it was all the people who were not underweight or whose scores fell in this range. So it is really a big mystery to me. Though I can say from a thematic perspective, what I observed shift in this group of people was that all of them had a really significant and transformative experience around reprioritization of the value of weight and shape. So essentially, that's one of the cardinal features of anorexia, is that, there's an overvaluation of shape and weight. And what that looks like is that people are prioritizing that in their life. So they if their friends invite them out to dinner, they decide not to go because they're more concerned about not eating than they are about socializing, right? And a lot of their actions are really sort of focused around maintaining weight or losing weight and maintaining shape, for example. And we saw a huge transformative shift in people kind of reorganizing their value system, coming out and saying things like, I spent so much time on that and it feels trivial now, right? Or I realized that
Yeah.
like I'm more than that as a person, right? So that was one core theme that I think really differentiates those four people.
I'm looking here through the study, and I like how you actually have a quote from one of the responders, and correct me if I'm wrong here, but it says that like two of the responders actually showed that they had a positive trend in their weight. One
Mhm.
was stable, and then one showed a decrease. Um, and one of the I'm guessing that the one responder who had a decrease in her weight, she had said, the irony is that now that I want to recover, I can eat intuitively, but that's not enough to support physical recovery. And so I'm wondering if
Yes.
that may be that like psilocybin is, part of a much larger treatment program.
I love that. Yeah. And I mean, I have a million things to say about that. So thank you for bringing that up. But I'll
And we have
start
no
by
word
saying,
limit. So go for it. This is
amazing.
not nature.
So multiple components here. The first is what you just said. And, I think that um, something that I really love about and what I think brings tremendous value to our field is that most of our currently available treatments are really focused on nutritional rehabilitation. So if you go to a PhD program, if you're in a residential program, there's a large focus, as there should be, on restoring weight. And that's important because, of course, physically it's dangerous to be underweight, but also we know that when someone's weight suppressed, it can affect cognitive symptoms. So that is a pathway for recovery. So there's a lot of good treatments around mechanically restoring weight and hoping that that will help someone, quote, fully recover. But we know that there's a bunch of people who get weight restored, some of which are in our study, and are not cognitively remitted, right? So they continue to struggle with an internal eating disorder, which is like, first of all, a really hard badge to wear because now you're dealing with an invisible illness. And none of our treatments really, as I had said in the paper, have focus on reversing core symptoms. So many of our treatments will actually explicitly say, like, first, we're going to kind of prioritize behavioral changes around your eating, which again makes sense. But we really need better treatments that treat from the inside out, meaning like, what is happening on an underlying psychological level, neuropharmacological level that's causing someone to want to engage in these behaviors. And I think that is the value of these treatments, is that we are treating from a different direction. In none of our studies did we sort of prescribe a weight goal or a nutrition goal. We, as is customary in psilocybin and psychedelic studies, it was very participant directed. And so people got to set their own goals, but a lot of the sort of recovery elements that we saw were around feeling kind of more assured as a person, right? And we are lacking that in our field. So as you said, this is a nice complementary treatment. But I do think it's also notable that we didn't have an effect on weight. If you look at it, I mean, the best way to look at our study is actually, I think it's a large case series paper. So the way that you did is like, okay, how many people restored weight? But I do think that, again, this is really focused on targeting core underlying eating disorder psychopathology versus weight and weight rehabilitation. And I think that brings tremendous value to our field because we are lacking in those treatments.
Yeah, absolutely. And something else that I saw in your article was that notably 90% of participants reported that one dosing session was not enough. And
Yeah.
I wondered when they said that, did they have any additional input, like why they thought perhaps follow-up sessions would have been impactful?
Yeah, I love that question. Honestly, that's kind of one of my favorite findings of the study is like, wow, these people are reporting that this was not enough. And, one dosing is, I mean, typical in some studies. In other studies, there's two. In the other large anorexia trial that should be published by Robin Carhart Harris probably within the next year, they did 3 dosings, I believe it was. So one is limited, right? And yeah, the majority of people kind of just perceive that to not be enough. And what we heard was, I feel like this kind of like opened the gateway, but there's more for me to learn. Or sometimes it was like, something else that we hear a lot is like, I now see that I'm better. I think I could navigate an experience in a better way next time, which sort of makes sense to me as well. And then the other one was like, wow, I felt better for a little bit of time, but I need another dosing because it didn't last. So there was a number of different factors that came up there. And yeah, I'm going to look forward to seeing and comparing on one level the upcoming published study from that group, the Imperial group, Robin's group, and ours, because that'll be interesting because there was a difference across the number of dosings that were administered.
Yeah. And you said that you and your lab currently at UCSD, you have an
Mhm.
upcoming study that you're currently enrolling for, correct? Can you tell us a little bit about what that study
Yeah.
design is going to look like?
Yes. So we're currently recruiting and seeing participants in a larger randomized controlled trial. So, and that's of course just to, that's a phase 2 study. So we're looking at, better establishing efficacy. So people are randomized to either, the full dose of therapeutic 25 milligram dose of psilocybin or what's considered a placebo dose, a 1 milligram dose, right? And they receive one dose in conjunction, like I said, with psychological support, which looks like 2 prep visits and 3 integration visits as well. That's a Compass sponsored trial. So we are one site amongst many who are conducting that. So other sites include, there's other sites across the world that are also conducting that site. And I hope that, there will be a lot more information that comes from just, being able to study a larger group of people.
Yeah, absolutely. And forgive me that I missed that this is another one session study
This is
design?
another single
Yes.
session, yeah, at this time, yeah.
Okay.
And
And I
yeah,
go
I
ahead.
mean, I think sorry, I was gonna say that I do think it's interesting to think about because on one level, I mean, even our pilot study suggests that a subset of people responded in the short term, right, to a single dose. So it is helpful to not have to dismantle to do 3 sessions and say, well, what would have happened with one, right?
Right.
So I think I see this as kind of like an iterative building approach, which I think is helpful.
Yeah, absolutely. And if you could postulate a little bit on, we've been talking about psilocybin, but do you think, we found over the years, and I say we, but I mean as a field, have found that a lot of psychedelics do a lot of the same things, right? Like a number of them
Mhm.
have been shown to be efficacious for PTSD or depression.
Yep.
Do you think the same thing may show up for anorexia?
Yeah, it's such a great question. Like, what is the mechanism, and is it just the transdiagnostic mechanism, right? And I do think that's one of the reasons why there's such a strong theoretical rationale to apply psilocybin to eating disorders, because many of the things that we see occur with psilocybin, like an improvement in cognitive flexibility, are extremely important and part of the puzzle of anorexia, right? So that's the first, right? Is like, can we occasion more cognitive flexibility, right? And we know that one of the signatures of anorexia can be sort of a rigidity, ritualistic behavioral patterns, just sort of rigid preoccupations and obsessions around the way that you think about food. And so that might be one avenue through which psilocybin may work. And similarly, just kind of occasioning a window of opportunity for behavior change. And so this goes back to the fact that, people often get stuck in these rigid and ritualistic ways of behaving around food and eating, and they're difficult to change. People will talk about how they want to change them and they can't. And so, can psilocybin open up kind of a window of neuroplasticity and opportunity to make that where we can leverage behavior change as well? So those are some potential features, and I think huge is that. And again, this lines up with our kind of thematic findings from our study, which we hope to publish in a qualitative paper. But one of the main things is that I do think that sometimes these transformative experiences can reorganize values and identities, right? And one thing that distinguishes anorexia is that it's a really eclipsing identity. People will talk about how their anorexia is such a core part of their identity, right? And in some ways that makes it difficult to treat because they find value, right? They'll say things like, well, I'm a better liked person at this weight, or I do this and it makes me feel better, right? And one of the things, once again, that we saw and that I think that psilocybin can occasion is sort of a reorganization of value systems, and people coming out and saying, wow, my my weight and my shape isn't the most important and prominent feature. And I actually do want to spend time connecting to these other identities. And so I think that holds tremendous value for such an egocentric disorder like anorexia potentially as well. And again, that's one of the big themes that we saw in our pilot study.
Egocentric is now my new favorite word. I've never heard that before. I like that.
Yeah.
That describes a condition that is kind of like intricately tied to one's ego.
Exactly, right. And that is one of those sort of distinguishing features of anorexia that we think makes it difficult to treat. And, a lot of people, roughly 20% of people with anorexia will develop a chronic course. Relapse rates are high. And part of why we think that can occur is because it is egocentric in nature. And like I said, whereas like if you have, let's say, depression or anxiety, you're able to say, oh, this thing, and I hated it, it ruins my life. A lot of times people with eating disorders are not able to undo who they are outside of their eating disorder. And it's such a core part of their self-worth that it gets unraveled in their ego in that way. And so then you could see why it's difficult to show up for treatment, right? If you're ambivalent about whether you want to get rid of something or not.
Yes.
Yeah. So all these sort of ego experiences and I think ego effects, right, in psilocybin are potentially valuable for someone with anorexia.
Yeah, absolutely. And by the way, I forgot to ask this back when you were saying it, but what does PHP stand for?
Oh, yes. I'm so sorry about that. So day treatment, so partial hospitalization program, which often, if someone's not responding to outpatient, they'll go to like a day treatment program that looks like receiving 8 hours of care in the way that you'd think of residential, but without the overnight element of it.
Got it. And you were talking about the reopening of windows, and that we're often, studies have been talking about this critical learning window, or,
Mhm.
and I think there was recently the paper that came out that said that that window was basically proportional to the amount of time of the trip. And so like ketamine had opened the shortest window because it's the shortest journey, psilocybin somewhere in the middle, and then ibogaine had the longest. So I'm imagining that, there may be some indication in the future to study something like ibogaine in really refractory. For as intense as it is, and these poor people that have already got like an electrolyte imbalance, I know that might be medically more complicated,
Yeah.
because it has the most cardiac complications. But do you think that that idea behind like that opening that window being one of the crucial elements, like you said, of being able to relearn, rewire patterns,
Mhm.
re-examine your identity, might lead to something like, these longer journeyed psychedelics having a role?
Wow. Yeah, it's such a great question. And I think until we are able to reliably better solve the puzzle and offer people better treatments, we should continue to explore novel avenues in the way that we can. So yeah, that I think that is really important. And again, I do think that in particular what you're talking about for anorexia, because this behavioral signature is so strong and it gets encoded in the brain as habit. And then therefore it's really, really difficult to change. And we did have people who came out feeling like their trip was meaningful and they had a different relationship with their eating disorder. And yet behaviorally, that pivot, right, to behavior changes that are required for recovery was very difficult to make. And so I think this idea of sort of opening up a larger window where behavior change is easier is extremely important. And I imagine that there will be um, indication specific interest for exploring other drugs like that for anorexia.
Yeah. Can you tell people where they can find the study that you're currently recruiting for, and then more about your work in general?
Thank you. Yeah, absolutely. So, like I said, I am a associate clinical professor at UCSD. So we have a large eating disorder treatment center. It's actually one of the largest non-private equity academic oriented PHP centers in the country. So we're really proud of that. And we also do neuroimaging research there. And so you can go to eatingdisorders.ucsd.edu to find out about all the studies, including our psilocybin study that we're currently recruiting for. Yeah, lots of information about that work. And then our Nature paper is open access right now. So if people are interested in reading up on that, they can find it there. And yeah, did that answer your question? Was there another part of
Absolutely. Yes. No, absolutely. And we will put the link to the Nature paper in the show notes as well. But I put in psilocybin, Stephanie, Nature, and I think it came right out. up. So if people are looking for it, but I really appreciate all the work you're doing, and I really appreciate you coming on and sharing it with us. And I look forward to having you on in future episodes to hear the follow-up.
I know there's so many questions to be answered. And I have just in kind of being closely attached to working with real people, just like so many, again, it's more questions than answers at this point. So I look forward to learning and all of us learning together.
Well, thank you again for being on, and for everybody else out there, until next time. Thanks so much for listening to the Psychedelic Medicine Podcast. If you enjoyed what you heard, please leave a rating or review, as it helps others find the show. And if you'd like to learn more, you can find the show notes at plantmedicine.org/podcast, and there's information for clinicians at psychedelicmedicineassociation.org. Our incredible music was by the one and only Porangi. We'll see you next time.